testimony. It is no secret that our country faces many healthcare crises. Too many of our people are uninsured or underinsured. We pay by far the highest cost for healthcare of any major country on earth. Cost of prescription drugs are off the wall, and many people can't afford that. And in the midst of all of that, for whatever reason, and I think we'll delve into that today, our nation, the richest country in the history of the world, simply does not have enough doctors, nurses, dentists, and other medical professionals. And why that is so, I'm not sure, but I hope we can learn something about that. But the result is that according to the Association of American Medical Colleges, by 2033, the United States will have a shortage of up to 139,000 physicians. And primary care physicians, and we already have a crisis in terms of access to primary care for many people throughout this country. Primary care alone will be facing a shortage of up to 55,000 physicians. And by the way, as we all know, this does not take into account what COVID-19 has done to the health profession. Anecdotally, I have heard from hospitals, many nurses just exhausted, leaving the profession. Hundreds and hundreds of medical professionals have died as heroes and heroines fighting COVID-19 and protecting the American people. But no question that healthcare professionals have taken a very big hit as a result of COVID-19. The federal government, as we all know, plays an enormously important role in how many physicians we have, because through the Medicare Graduate Medical Education Program, we fund the vast majority of residency slots in this country. In 2015, the most recent data available indicates we spent about $16 billion on graduate medical education, providing for roughly 31,000 residency slots a year. Last year, Congress added 1,000 additional slots. That's a step forward, but it is nowhere near enough, I think, to address the crisis that we face. Very importantly, I think, maybe we can discuss this a little bit today, in addition to expanding those slots, Congress did expand the Teaching Health Center Graduate Medical Education Program. And that is a much smaller program than what Medicare does, but it focuses directly on the needs to get doctors and others into medically underserved areas. Very shortly, I will be introducing legislation to address the multiple crises we face, and I just want to very briefly touch on what that legislation will do. Number one, and I hope some of our panelists will speak to this issue as well. I learned, Senator Collins, recently, calling up New England medical schools, as a matter of fact, that the number of medical students per class is a lot smaller than you would think. For example, if you look at Dartmouth or UVM Medical School, we're talking about 90 or 100 students per class. Now, I know that it's an intensive effort to train a doctor, but I would think maybe we want to explore whether we can produce more doctors through larger medical school classes. 90 or 100 per class seems a little bit small to me. Clearly, we also, and there's, I think, widespread bipartisan support for the understanding that we need to increase payments for direct graduate medical education. The legislation that I will be introducing picks up on work being done by Senators Schumer, Boozman, Menendez, and others, would authorize 14,000 new Medicare-supported medical residency programs, positions over 7 years, 2,000 a year, in addition to what we have. Further, and very importantly, what our legislation would do is to establish new criteria for how the new GME training positions would be allotted to qualifying hospitals, with a minimum of 50% of new slots going toward primary care. In other words, the crisis we face is not only a shortage of doctors, is where those doctors are. They're not in rural Maine. They're not in rural Kansas. and they're not in rural Vermont. We have a hard time attracting them. We do not necessarily need more dermatologists on Park Avenue in New York City. I don't know if we do or not, probably not. But we do need them in rural areas all over the country. And we have to make sure that Medicare understands that. Another issue that maybe panelists can pick up on, I think we all know that residents are really underpaid. You go 4 years to medical school, you do a year of internship, and the average pay for a resident is $63,000 a year. So you got medical debt, right? You got a few $100,000 in debt. Oh, is that right? But it's, well, costs have gone up a little bit too. Yeah. But, you know, if you're living in a big city, you were making 20,000 and working long hours, I expect. Yeah, all right, well, that's another story. But here's one thing that gets to me. While the average resident earns $63,000, which I think is inadequate, primary care residents earn $58,000. So the discrimination starts right there in the residency program, not to mention what salaries are paid. Doesn't make a whole lot of sense to me. I think we should increase, and our bill will significantly increase funding for the Teaching Health Center Graduate Medical Education Program. We have made progress. I'm happy to say that in the American Rescue Plan, some of us worked very hard to double funding for community health centers and triple funding for the National Health Service Corps. And I think we have to continue that effort. So that says to somebody, if you're going to be graduating medical school $300,000 in debt, you ain't going to rural Maine, frankly. All right? And we're going to help you pay off that debt if you do go to rural Maine or rural Vermont or rural any place. So that's some of my thoughts, and I look forward to this serious discussion.